Hello friends, my name is Dr. Saf and you are watching your own channel which deals with authentic study material for your exams. Let's embark further into second video of decoding ventilator waveforms. In previous video, we analyzed pressure scalar morphologies in normal lungs and in various kinds of pathologies. Compared to pressure or volume scalars, the flow time scalar provide plethora of information because its dynamic shape is highly sensitive to changes in airway resistance, lung compliance, and patient effort. Inspiration is conventionally displayed as a positive value above the baseline, whereas expiration is displayed as a negative value below the baseline. Alright, so this is the way flow time scalar represents on ventilator screen. Basically, there are two types or two patterns of flow scalars, square wave and decelerating pattern. Square wave is most commonly seen in volume control and decelerating pattern is commonly observed in pressure control. Alright, but nowadays in the modern ventilators, even decelerating pattern can be observed in volume control mode. There is an option on volume control mode in modern ventilator where you can switch the flow patterns. However, there is another flow pattern which also can be seen. So this is the sine flow where you will see the flow gradually increases to a maximum at mid inspiratory time and then decreases back down to zero, often used in a spontaneous or pressure support mode. Its main significance lies in the fact that it provides a more physiological flow pattern mimicking spontaneous breathing. So it may improve patient comfort and synchrony compared to square wave. So they say that sine wave is better physiologically compared to square wave or square flow pattern. However, it is less efficient in terms of gas distribution than the decelerating RAM, and peak pressures can be higher than with pressure controlled decelerating flow. So this is the reason sine flow is not commonly used in modern ventilators. Okay. So if somebody asks you where the sine wave pattern is seen, you can say CPAP without pressure support. Okay, in that case you would see the sine wave flow pattern. Now expiratory decay curve, which is very important here to see. This is the expiratory decay curve. So expiratory valve opens here and then the flow rises to a peak, and then from here onwards it starts descending like this or decay like this. Okay, this is your exponential decline of flow back to baseline, which reflects elastic recoil and airway resistance both. Suppose there is high airway resistance. In that case, the peak flow will be reduced, okay, and the decline will be prolonged. Okay, expiration will prolong. Okay, in case of high airway resistance, like this. All right. Now let's see what is the abnormality here. If you look at closely, inspiratory flow is somewhat square wave, but the expiratory flow is what looks abnormal here because there is incomplete baseline return of flow, expiratory flow. So expiratory flow does not reach to complete halt and there is some air left here, okay, which is called auto-PEEP. So the scooped out appearance can indicate issues like increased airway resistance. So this is your auto-PEEP. All right, so it happens because of increased airway resistance, such as in case of asthma, COPD, bronchospasm, etc. And it can also happen when IE ratio is ignored while increasing respiratory rate. So it's very important for every one of us to pay attention to IE ratio while we increase the respiratory rate. So when there is incomplete time for exhalation, this situation may arise. And in any case, give bronchodilator if there is bronchospasm. Take care of endotracheal tube secretions and kinking of circuit, endotracheal tube biting, etc. All these may be reason for development of auto-PEEP and this kind of expiratory flow. And if such a case, you have to treat case by case. In most of the cases, you administer the bronchodilators, and it is very important to prolong the expiratory times and adjustment of IE ratio. and also measure the intrinsic PEEP. It's very important. So air trapping can occur in such cases. So what's happening here? Can you tell me? So the answer is in front of you. There is expiratory. This is expiratory hold maneuver. As you can see, there is increase in the baseline and it sustains before next inspiration starts. So this is done after keeping the PEEP 0. So this is expiratory hold maneuver, which gives you the auto-PEEP level. This is the measure of, or this maneuver is done to measure the auto-PEEP. What's happening here? Can you tell me? So it's a flow time scalar. In inspiration, there is a dip or concavity. Can you see? There is a dip or concavity in an inspiratory flow, and this is M pattern, which is observed in flow starvation. The most common sign is a concave or scooped indentation in the normally ascending pressure or curve. When a patient wants more flow than the ventilator is delivering, this condition is known as flow starvation or flow dysynchrony or air hunger, which occurs when the flow of gas the mechanical ventilator delivers is lower than the patient's immediate inspiratory demand. And this asynchrony is most commonly observed in volume control ventilation modes, where the flow rate is typically a fixed square wave pattern, which is set by clinician. Severe flow starvation can lead to other asynchronies such as double triggering, where the patient's prolonged inspiratory effort causes the ventilator to deliver extra breath immediately after first one is completed. So that can lead to double triggering. So this is the flow waveform. Here inspiratory flow continues into second breath. Can you see? So this is the second breath with a scooped appearance, and this is classically observed in double triggering, which is a type of asynchrony. Alright. And key hallmark of this flow asynchrony is the presence of two distinct breaths with two separate flow peaks. Can you see the two separate flow peaks? So the first one is the normal one, and what happens, the inspiration continues, and that is the reason there is another one. It often signals high patient respiratory demand. For example, in case of anxiety and pain, patient will be having a lot of demand. Even in case of metabolic acidosis, such as in case of DKA, patient will have higher respiratory demand. In that case, there will be double triggering. Now, what is this? This is also very important to know. So there is a successive, breaths. So these breaths are because of auto triggering of the ventilator, which is responsible for this kind of waveform. So the auto triggering is inappropriate triggering of ventilation when the patient is not attempting to initiate a breath, and it may occur in case of hyperventilation, even if patient is heavily sedated, and also it can occur in case of significant air leak and circuit condensation, and it's especially seen in patient where we are delivering the chest compression during the CPR. That time also the ventilator will be auto triggering the breaths. So the treatment is to look for air leak in the circuit and a condensation issue. This has to be looked for and treated. And here sometimes you can adjust the trigger. So flow trigger or pressure trigger, you have to basically increase the trigger so that the sensitivity of the ventilator will decrease. So you have to adjust the trigger. Now look at this waveform. Here what you see, there is some issue with the expiratory flow, isn't it? There is an upward deflection during its early expiration. This is called reverse triggering. Reverse triggering. It is a patient ventilator asynchrony where the patient's diaphragm contracts after the ventilator starts a mandatory breath, often due to deep sedation or neurological issues. Even it can occur in patients who are neurally dead. I mean, the brain dead patient can also have this kind of reverse triggering. The patients who are on relaxant, heavily sedated, and it causes breath stacking basically and lung injury. So it's not good for the lungs because it can cause the increase in the tidal volume suddenly and breath stacking, and because of sudden increase in tidal volume to 10 to 12 ml per kg, there could be lung injury caused by ventilator itself. So reverse triggering has been described in patients even after brain death, as I said. Alright. Identify the abnormality in flow here. So there is an issue in both inspiration and expiration, as seen, as you can see arrows. Okay, so upper one and downward, both flows are having some issue. So patient is on pressure control mode, but there is no patient triggering, no negative deflection at the start of inspiration. As you can see in the pressure time scalar, there is no negative deflection, so there is no patient triggering. However, deflections are seen in both inspiration and expiration. Flow should be decelerating, but during the late phase of inspiration itself, there is patient's effort, as you can correlate with the pressure scalar above. So there is a patient effort here, and because of that, there is a dip in the pressure scalar, right? So there is a triggering happening, which is basically a reverse triggering, which is happening in the late phase of inspiration and early phase of expiration. Again, another one, you see positive upward deflection here. Can you see? Actually, a patient effort seen after the ventilator breath here. Sedatives does not eliminate RT. Remember that reverse triggering cannot be treated with the sedative. It will persist even more. In such cases, it is better to change the mode sometimes, and you can increase the inspiration. Now what is happening here? See, so there is expiratory flow which is quite prolonged, but something is happening here. If you look at here pressure, you will know what is happening here, and this is the esophageal pressure. There is a negative pressure here, so there is some effort by the patient which is causing negative deflection in the inspiratory pressure, as well as there is some. So this is basically a failed trigger or wasted effort, otherwise known as the ineffective triggering. So this effort is not detected by the mechanical ventilator, and there is no breath following this trigger. So basically this trigger is missed by the ventilator. Okay, and this is common type of patient ventilator asynchrony. So auto-PEEP is the leading cause of ineffective trigger. Remember that. Air is trapped inside the lungs at the end of exhalation because the patient doesn't have enough time to fully exhale. So in that case, the patient must generate a strong enough initial effort to overcome this positive pressure threshold before the machine can detect a change. Other important reasons of ineffective triggering could be insufficient trigger setting. Okay, so sometimes you set the trigger too high and make the ventilator insensitive to the patient's effort, and sometimes there could be muscle weakness and excessive sedation or low respiratory drive. All these could be the reason of ineffective triggering. So normal trigger is this. Okay, but what happens is that in case of PEEP, the trigger which is required is more. Okay, more trigger is required in case of PEEP because of extra pressure. So harder force has to be generated by the patient, harder flow has to be generated, more flow has to be generated, and this is the reason it cannot be generated enough. That's the reason ventilator does not get triggered, and this is known as ineffective triggering. Now we will talk about cycling asynchrony. So cycling is the change of inspiration to expiration. So inspiration to expiration can happen little early or little late. Accordingly, cycling asynchrony can be early cycling issue and delayed cycling issue. So there is the neural time and the ventilator time, and there is mismatch. Okay, so this mismatch can result in the breath ending too early or too late relative to the patient's neural inspiratory time. Now let's see the example. So here what you look at, the inspiratory time is quite short here. Okay, because of that, what is happening, the breath is ending early. So immediately after ventilator cycles to exhalation, you see there is sudden upward spike or concave distortion in the initial expiratory flow, and this happens because the patient's ongoing inspiratory effort pulls against expiratory flow, suggestive of premature cycling or early cycling. Okay, and you can argue with me that there is some reverse triggering occurring. So very difficult to say sometimes. In case of premature cycling, reverse triggering could be there. So this situation can lead to high tidal volume generation despite the shortened inspiratory time because of second breath which can occur, or double triggering, or even reverse triggering. There could be high tidal volumes, okay, and breath stacking. And now here again, what you are looking at here, see. So better to see this part of curve, or even here also what is happening. This is the pressure time scalar, where the last phase of inspiration there is some bump or upward spike. This happens because the patient's expiratory muscles are contracting against a closed inspiratory valve, causing a localized pressure increase here. Okay, why it is happening? If you look at it, there is an increase in the inspiratory time. So what is happening? The breath is ending too late, and this is known as delayed cycling. So ventilator's mechanical inspiratory time is longer than patient's required neural inspiratory time, and this asynchrony is not good. The patient starts to exhale while ventilator is still trying to push air in, which causes a spike in the airway pressure and can increase the patient's work of breathing, and can lead to something which is called auto-PEEP, air trapping, etc. because expiratory time is shortened, and this is common in patients with obstructive lung disease. Now we will discuss the volume scalars, which are important to be observed, especially for leak. So remember, volume scalars are very good to observe for leak. So volume is usually not measured directly except for piston ventilators, but it is derived from flow measurements. Usually the flow sensors are there which calculate the volume as the flow into time. So, or area under the flow time scalar is basically the volume. Okay, so there is upslope which represents the inspiratory volume, okay, and there is a downslope which represents the expiratory volume, and then here you can see there is a plateau phase which is basically caused by the inspiratory pause. Okay, so any plateau between the two, inspiration and expiration, is basically and inspiratory pause, which is sometimes optional, all right, which you can make 0. So inspiratory and expiratory tidal volume may differ slightly due to accuracy of flow measurement as well as differences in the temperature or humidity of gas. But if there is a large discrepancy between the inspired and expired tidal volume, say more than 5 to 10%, which can actually a significant gas leakage, and that's not good. That will result in the hypoventilation. So what is happening here? Volume is the expiratory volume. Expiratory volume is scalar is not reaching the baseline. So before reaching the baseline, there will be start of inspiration. So as you can see here, so this is the expiratory volume which is not reaching the baseline at all, and suddenly inspiration starts. So this is very typical case of leak. The most common causes of such kind of leaks are circuit disconnections, poor cough seal, interface leaks, or pathological fistulas like bronchopleural fistula, and sometimes it is intentionally done. Sometimes it may be asked by examiner, what is the intentional cause of volume leak? The answer would be that intentionally it is done during cough leak test. All of you know about it, right? The cough leak test for the assessment of risk of post-extubation stridor. So in our hospital, cough leak test is done by respiratory therapist usually. So what they do is just to deflate the cough and assess both inspiratory and expiratory volume. So this is numerical, or you can look at the percentage leak, and also you can look at the volume scalar. So tolerable leak should be less than 10% of tidal volume. That's what they say. And in case of cough leak also they say it should be more than 10%. Then only you can go and extubate the patient, otherwise try not to extubate. Now this is the last slide for all of you to tell me what is going on here. So there are some oscillations, right, in the flow and scalar, flow scalar and pressure scalar both. So what's possibly happening here? Tell me in the comment section. So we have finished pressure time scalar in our first video, which was quite long, and then we finished the flow and volume scalars in this video, the second part. Now in third part we would like to discuss the loops. The loops are also very important, And let me tell you, more you read about the graphics and scalars and loops, etc., more you will become confused and easily you will forget. So my point is, and my suggestion is, that you should be looking at the ventilator graphs very frequently and try to analyze the pattern. Take a picture when you are bedside. You all have smartphones, so don't hesitate, take a picture and try to discuss the waveforms with your colleagues, with your seniors, your mentors, your teachers, everybody. So try to do that and try to learn yourself everything. It's not that big deal. So that's all for today. Thank you. Take care. Bye bye.